Morning. My name is Borja Ibanez. I'm a cardiologist working at the Spanish National Center for Cardiovascular Research and also an interventional cardiologist at Hospital University Fundación Jiménez Díaz. So today I'm going to be presenting the case for the PolyPill or precision medicine where there is room for. So I don't have any personal conflict of interest to declare. However, it's important that I highlight that my center, which is a non-profit public institution, receives royalties for the sales of a PolyPill, which is composed by aspirin, ramipril, and atorvastatin, even though no researcher has any direct interest to receive any personal benefits. So I'm going to focus on atherosclerosis because, as you all know very well, this is the epidemics of the 21st century. So there is an alarming increase in the incidence and prevalence of atherosclerosis and its clinical complications, and there is a strong need in order to improve prevention of this disease to be able to tackle these epidemics. So I'm going to focus on the three different aspects within the next 20 minutes. The first one relates to the dark side of success. In fact, we have witnessed within the previous decades that there have been a significant reduction in mortality associated with cardiovascular diseases. Here is a very nice paper published a few years ago by Professor Brownwell, showing how the main landmarks in cardiovascular medicine or cardiovascular trials has resulted in a significant reduction in all-cause and mainly cardiovascular-related mortality. However, the side effect is that we have now an downstream consequence, which is that we have a big population which live with the consequences of atherosclerosis and cardiovascular disease. In fact, if you see to these both graphs, you will see that the most share of the healthcare costs are related to cardiovascular diseases. In fact, more than 50% of all healthcare costs are associated with these diseases. In fact, there are projections that if these epidemics continue to grow, we might reach a point in which we might have very good treatments or very good strategies to treat patients with cardiovascular disease, but the healthcare systems are not going to be able to cope with this problem. So it's critical that there is a need in order to prevent this alarming increase in cardiovascular disease and its clinical complications. So therefore, this leads me to the second main aspect and the central aspect of this presentation, which relates to the need in order to improve prevention, which certainly outperforms treatment disease once clinical manifestations have occurred. We know, and this might be seen as one of the first precision medicine endeavors in cardiovascular medicine, which is the identification of risk factors associated with myocardial infarction and other atherosclerotic-related clinical manifestations. This is coming from the Framing Heart study, in which the main or traditional risk factors were identified, as you know, hypertension, cholesterol, smoking, diabetes, and later on some others. But this was the main study showing that it was very important because not all the population was at the same risk to develop atherosclerosis and its clinical complications. In fact, we have been using these classical equations, and this one is coming from the Framingham study, in which based on several factors such as gender, smoking status, hypertension, or cholesterol, were able to predict what is the risk of a population. So those who have more burden of cardiovascular risk factors, they have higher chances for developing clinical consequences of atherosclerosis or atherosclerotic heart disease. In fact, recently this has been significantly refined, and this is a recent paper from the European Society of Cardiology in which a score that is for the European population has been developed. And different to the previous score, not only this score takes into account cardiovascular risk factors, operational risk factors, but also it takes into account what is the baseline risk from a certain population. In fact, we can see here that for these scores, sex-specific risk prediction models are done. This score predicts the estimation of the 10 years risk of fatal or non-fatal cardiovascular disease. And what is even more important, as I mentioned before, is that it takes into account the baseline risk for the population. So, for example, you can see here that for a given person, which is a 50-year-old smoker with a systolic blood pressure of 140, with a relatively high cholesterol and relatively low HDL cholesterol, the risk for a female can vary from 4% to 13% according to the different region. And this can be also between 6% and 14% for males according to the different regions. So again, this is showing us that precision medicine is advancing also in primary prevention, and is not all the different risk factors have the same impact on different populations. we can explain why this vulnerability of different populations is different across different countries, but also there are many other factors that are completely unknown for us. But what is clear is that the risk entailed by risk factors is not the same for different populations. In fact, these risk equations have been proven to work very well at the population level. However, at the individual level, there is a lack of precision. This means that if you take a population which has more proportion of people with hypertension and diabetes and another population which has less proportion, the overall incidence of cardiovascular disease clinical events are going to be higher with the population with higher risk factors. However, at the individual level, it's extremely difficult to identify which person is going to develop symptoms related to atherosclerotic heart disease. So this is why there have been a great interest in developing new tools who can improve the risk prediction and some sort of precision medicine. And from all those, I'm going to be focused on cardiovascular imaging, because this is a tool that most probably has been demonstrated, as you will see in the next slide, that is able to re-stratify the risk, and is a clear risk modifier, and also because we have been working with this tool within the previous decade extensively. This is one study published by the group of Professor Valentin Fuster in New York, and is coming from the cohort study, which is the HRP. In this case, this is the bioimage study, in which a population of persons without clinical manifestations of the disease, so therefore this was a primary prevention study, they underwent imaging of atherosclerosis in the carotid territories by ultrasound and also in the coronaries by calcium scoring. And you can see here that it's clear that the cumulative incidence of major adverse cardiovascular events was higher in those subjects we have a higher burden of disease in the carotids by ultrasound, and also this was higher for persons who have higher burden of calcification in the coronary arteries. And this was the case after adjusting for classical risk factors. So therefore showing that the risk can be re-stratified by identifying directly the disease. In fact, these two imaging, the coronary territory and the plaques in the carotids, can entail significantly increased risk when both of them are appearing together. Because if you see here, for example, the plaques in the x-axis, persons without atherosclerotic plaques in the carotid, they have lower risk compared to those which are in the highest tertile of carotid blood burden. And here in this axis, you can see that this is also the same for coronary calcium scoring. And if you pull all of them together, subjects who are at the highest tertile of carotid plaque burden and also of coronary artery calcification, they have the highest risk compared to others which might have the highest tertile in one imaging but not in other territories. So this is clearly showing that imaging can improve precision medicine for the identification of the risk in the primary prevention area. But as you can see here, this population from the HRP was a population of relatively intermediate to high risk because the age was close to 70 years of age. So we might argue that eventually, even though we were able to re-stratify the risk of this population, eventually there is not much room for curbing the progression of the incidence or the cumulative incidence of cardiovascular events. So this is why we wanted to perform the same study showing how imaging can re-stratify the risk, but in a much younger population, because eventually the room for improving or for increasing prevention of developing clinical symptoms would be significantly higher. So this is why more than a decade ago, we launched the PESA Zenit Santander study, which is a cohort study, longitudinal prospective cohort, which recruited 4,200 asymptomatic middle-aged bank workers. They were between the age of 40 and 55 when they were recruited. And this is being done in collaboration between the Spanish National Center for Cardiovascular Research and the Bank of Santander, because we can follow this population very easily because they are working in a very confined area. And the principal investigator for this study, again, is Professor Valentin Fuster, who is also the General Director of the National Center for Cardiovascular Research. In summary, this population of 4,000 middle-aged asymptomatic participants, they undergo every 3 years a very comprehensive imaging screening. They undergo carotid and femorals and aorta ultrasound in order to identify plaques at different territories, not only carotids as the previous study, but also femorals and aorta. Also, they undergo what we call advanced imaging, not only to identify the plaques, but also the metabolic activity. And also, they are undergoing blood sampling every 3 years in order to perform plasma and single cell only studies. Also, these subjects, besides carotid and femoral ultrasound, they undergo also coronary artery calcification studies, and we have been repeating this every 3 years, all imaging and also blood sampling every 3 years, as you will see. And then we have recently renewed, and then we are going to follow up this population at least for 10 additional years. So we are going to have this population being followed up for more than 20 years. So this is going to be a massive endeavor in which we're planning to identify to track atherosclerosis from the very early stages to the transition for clinical events. One of the most interesting or the most striking results that we had was one of the first publications from the PESA. Here you can see what is the prevalence of disease in the different territories. And you can see that overall, in males, the prevalence of atherosclerosis is above 70%, and in females is 50%. So this is extremely striking because this is middle-aged, theoretically asymptomatic or asymptomatic and theoretically healthy active workers. So almost 63% of the population, 65% of the population, they have already atherosclerosis. And this is telling us that it's really difficult to fight against these epidemics of atherosclerosis because in the end, this is a behavior disease, and most of their traditional way of behavior, of traditional way of acting, most probably is associated with the development of atherosclerosis. So this is clearly showing that there is a clear need to identify preventive strategies in order to prevent this population who already have the disease to make the transition towards clinical events. Interesting also, we have seen that there is a discrepancy between the traditional risk equations. We have seen before the Framingham risk scoring, also the European score, but in this slide we are presenting you the Framingham risk scoring. In this population, you will see, for example, here in the 10 years risk score, you will see that there is much of the population is considered at low risk according to the traditional risk factors, and then we have some population that is considered to be at high risk. But what is extremely interesting is that you will see that there are populations that are super protected or they are super vulnerable, which means that, for example, here, despite the population is at medium or high risk at only 10 years, they have no evidence of disease. Because I forgot to mention that what is below the zero axis is that there is the proportion of subjects without atherosclerosis, and here in the different colors, you will see that these are the different territories. So meaning that here in white is only one territory affected by atherosclerosis, 2 or 3 territories, or more than 4 territories. But what I was trying to highlight is that there is a population that, despite they are considered medium to high risk at 10 years, they do not have atherosclerosis at all. So these are super protected population. And on the other hand, you have a population which is considered to be at low risk at 30 years, which means that this is a very low risk population, but still they have extensive atherosclerosis. And this is what we call the super vulnerable population. So this is extremely important because we believe that precision medicine plays a critical role here, because trying to identify why this population, they are super vulnerable and this other population is super protected, eventually might help us to better refine the risk of the population and also to implement some preventive strategies. Within PESA, we have made several major contributions. We have recently published a paper showing the 10 most important contributions from the PESA study. I'm not going to go into detail, but this is just to show that this study is clearly tackling precision medicine in primary prevention, because we have made some important discoveries, and all of them highlight that there is a clear role for precision medicine in primary prevention. In fact, clinical practice guidelines already include precision medicine in primary prevention. This is a slide from the recently published or recently launched European Society of Cardiology guidelines for cardiovascular disease prevention in clinical practice. And you will see here that besides the classical quantification of the risk or calculation of risk of individuals, it's very important to take into consideration what they call, or what we call, risk modifiers. And from them, imaging is one of the most important tools as a risk modifier. So it's not the same to have a person with some profile of risk factors without evidence of atherosclerosis compared to the same person with the same risk profile, same cardiovascular risk factors, but with extensive atherosclerosis. It's extremely important that we cannot consider equal both individuals, and we have to take into consideration risk modifiers as a great example of precision medicine. And then this brings me to the last part of my presentation, which deals with the clear differences between real life and also between the clinical trials. So, real life is extremely complex. In fact, we have been talking about clinical practice guidelines, and here in Europe, we have a very important tradition in order to follow clinical practice guidelines, but it's very important to take into consideration that clinical guidelines, most of the times, they are based on randomized clinical trials, in which most of the population have been treated or have been approached in a really comprehensive manner. All of them, they have very clear inclusion and exclusion criteria. However, real life is much different. So there is a question whether these findings that we have in clinical trials truly apply to the real life. And one very important aspect that I want to highlight related to today's conference relates to the adherence to the medication. In fact, you can see here that this is a very classical and striking paper published almost 10 years ago, in which shows what is the percentage of patients who are adherent to the medication. And you can see here that the percentage of adherence in medication in primary prevention and in secondary prevention is significantly less than what you would expect. So no matter how good are the medicines that you are prescribing the patients, if they are not taking the medication, we're not going to be able to tackle these epidemics. So this is extremely important to implement strategies also to increase adherence and not only to identify new treatments that can reduce the burden of atherosclerosis. In fact, we can see here what is the impact of poor adherence to medication. This is a study in which data was obtained from insurance companies, and then the final population was composed by 4,000 post-myocardial infarction subjects or patients, and also 13,000 subjects without myocardial infarction but with evidence of atherosclerosis. And then this population was divided according to the percentage of adherence. So people was considered to be completely adherent when more than 80% of the time they were taking the medications, intermediate when the time taking the medication was between 40 and 80%, and poor adherence was when the percentage of time taking the medication was less than 40%. And you can see here what is the cumulative incidence of major adverse events, which is significantly higher in those subjects who are with incomplete or very poor adherence. This is clearly showing that no matter how good is the that we have, that the patients are not taking the medication, then we are not going to be able to significantly prevent the development of events. And when you go for the reasons of why the population or the patients are not taking the medications, you can see here in this very nice study that one of the most relevant factors behind the poor adherence to medication is the complexity of treatment. What is complexity is the number of pills. The more pills that the patient is prescribed with, the higher chances for not being adherent to the medication. So this is why when it comes to the concept of the PolyPill, which has been successfully used in different fields such as infectious diseases. But we thought that eventually cardiovascular disease was the ideal scenario, because most of the patients in secondary prevention, they take more than 4, 6, or 8 pills. And even in primary prevention, when there is a high prevalence of risk factors, also patients have to take several medications. So this is why PolyPill can tackle this problem of adherence. There have been several studies published in primary prevention. I'm not going to go into detail. This is a very nice paper recently published in Lancet that is a meta-analysis from 3 different trials testing PolyPill in primary prevention, the TIPS-3, HOPE-3, and also the PolyIran. And in this case, this is not clearly trying to tackle mainly the problem of adherence, but is mainly trying to tackle the problem that patients are not able to take the medication. So in this case, what they were comparing was against matching placebo. So this was not comparing to taking the medications independently. And then this was based on a PolyPill, which was a fixed dose medication. So we are not going to do titration, only just take the pill with a certain dose and then see whether we are able to reduce the events. And to make the long story short, you can see that in primary prevention, these fixed dose combinations of PolyPill containing several of the most relevant medications are associated with a significant reduction in cardiovascular death and minor stroke or revascularization, which was the composite endpoint. But of course, you can tell that if the control group is matching placebo, people is not taking the medication, it's normal that you are going to end up with the results as long as the patients are able to take the medication. However, in secondary prevention, the landscape is more complex because in this case, we are not comparing taking all the medications versus placebo or not taking the medication. But in this case, most of the studies, they have done a comparison of strategies. So one strategy is to prescribe the patient to the PolyPill, one PolyPill containing the most relevant medication for secondary prevention, mainly ACE inhibitor, statin, and aspirin. And in the other case, the patients are treated according to the standards, and then they are receiving a different pills. And the main hypothesis is highlighted in this slide. You see here that there are 3 main trials or 4 trials with the focus one, which is the one that we have been involved in. And in all of them, you will see that the strategy in which the medications are taken in a polypill containing all of them together is associated with a significant increase in adherence. And here you can see in the focus trial, which was the trial that was led by us, by Professor Fuster was the principal investigator, and we have been deeply involved. In this case, the Zenic polypill was associated with a significant increase in adherence. In fact, very recently it has been shown that not only the prescribing patients with the polypill increase adherence, but also these patients, they are reach the guideline targets more frequently than patients taking the independent medications alone. So you will see here that these are the different targets set by the European Society of Cardiology for different risk factors, blood pressure, cholesterol, and also the platelet therapy. And you will see that the probability of having the patients meeting these targets are much higher when the patients are prescribed with this polypill. However, as we wrote in one editorial a couple of years ago, although it is clear that the polypill is associated with a significant increase in adherence, there is still a need of data showing that these benefits translate into a reduction in hard endpoints in secondary prevention, as I mentioned, and comparing with the regular strategy of receiving all the pills independently. In order to meet this gap in knowledge, we are undertaking the secure randomized clinical trial, which again, the principal investigator, Borja Fuster, we are deeply collaborating with his group. This is a study which is funded by the European Commission. We have several countries here shown. And in summary, we have already recruited 2,500 patients who recently had a myocardial infarction, and they have been randomized to receive the standard of care or the polypill strategy containing aspirin and ACE inhibitor and statin, ACE inhibitor, and aspirin. These patients have been followed up for a minimum of 2 years and a maximum of 5 years, and the primary outcome is cardiovascular death, MI, stroke, or revascularization. We already finished enrollment almost a couple of years ago. In fact, we are close to finish the follow-up, and hopefully late this year we'll have the results of this very important trial. And we will see whether this increasing adherence that has been demonstrated in secondary prevention by the polypill is associated with a significant reduction in major adverse events. So in summary, ladies and gentlemen, we have seen that there is a need to improve primary prevention strategies to tackle the atherosclerosis epidemics. If we are not improving primary prevention, if we are not improving prevention strategies, then there is a high risk for the healthcare systems to break and to crash down, and we are not going to be able to treat our patients with pharmacological interventions. Current algorithms based on classical risk equations work very well at the population level, but clearly fail at the individual level. So therefore, there is a need for tools to improve precision medicine, and we have been working with imaging as one of the most important tools to improve or to increase precision or to perform precision medicine. Real life is different from clinical trials. It's very important that patients adherent to medication is followed up. In fact, the adherence to medication currently is very low. So eventually, in this case, the polypill strategy can serve to increase basic medications, and therefore this should translate into a significant reduction in recurrent cardiovascular events. So in summary, and addressing the question which I was asked with, it's clear that there is room for both for precision medicine and also for a polypill strategy. I don't want to finish my presentation without acknowledging all the different funding agencies that allow us to perform our studies, and I'm going to be extremely happy to take questions from the audience on this topic. Thank you very much for your attention.